is so nice to have you back. Welcome back. We are continuing on with our discussion of developmental stages in children. And we're going to start out today by taking a closer look at anticipatory guidance. I mentioned it in the last lecture. And today we're going to take a look at some of the other topics that are of concern when we've got patients, families coming into a clinic setting and we're teaching. So nutrition is a very important one. Water safety, and that includes the use of sunscreen for children, making sure that they are getting swimming lessons if they are going to be around water. Seatbelt use is another important anticipatory guidance topic. Bullying, we have heard plenty about this topic in the last 20 or so years. Online computer safety is now a new factor that we are dealing with in this day and age. How to keep children safe when they're online and there are people out there who are trolling for children. Exercise, of course, goes along with the nutrition piece, right? We've got to be taking in calories, and we're hoping that we are expending an equal amount of calories to keep our weight healthy. Bicycle safety, which especially includes the use of wearing a helmet. Dental hygiene is so important during childhood, making sure that good habits are formed with brushing the teeth, certainly in the morning, certainly at bedtime, ideally more than twice a day, maybe even after meals. Hand washing, ever important topic, and learning how to do it properly, and learning how to do it after every time you use the bathroom, and really important times during the course of our day when hand washing or the use of hand gel should be utilized. And then stranger safety or stranger danger. So in other words, being able to teach children what to do in case they are approached by a stranger, and how to avoid an unfortunate situation. There's an interesting story, I may try to find the link and post it for you guys to watch, that I saw on YouTube, where a young mother of probably, I would say like a 6-year-old child, they're at the park, and she has spent the whole week before this teaching the child about stranger danger, teaching the child to never go with an adult who the child doesn't know, that's not a direct family member. And the child is fully understanding of this, right? They've kind of gone through this all week. So they do this experiment where she takes the child to the park, and she is seated on a park bench, probably about 50 or so feet away from the playground area. So the child can see her, but she is quite a ways away. And she can see the child too. And they had it planned that a young man who was very well dressed, kind of looked like a very respectable type college student type kid, probably around his early 20s, pulled up in his car, got out of his car, brought his puppy out, went up to the little boy and said, "How are you today? This is my puppy. Do you like my puppy?" And starts playing with the puppy. They're playing ball with the puppy, and it took about 3 minutes to get the child to just go right with this man, get in his car with his puppy. And the mother was absolutely floored because she had spent all this time teaching her child not to do the very thing that then the child did very easily within just a few moments. And so the reason I'm telling the story is because it's more than just teaching them not to go with a stranger, right? Nowadays, there are ways that children are baited specifically. Things like, I know that your mother's name is Mary Farmer. She told me to come here and get you because there's been an emergency. So you need to come with me. And then the child thinks, well, gosh, they knew my mother's name, right? Or even knowing your address or knowing your phone number and saying, you know, I know your dad. I know that he works at UH Maui College. I'm supposed to come here and pick you up and take you there right now. So that, and then of course the puppies or the candy or whatever, we really need to educate them fully to what the dangers can be. And we always just assume that a stranger who's dangerous would look dangerous. And that is almost never the case, right? They look like a perfectly safe individual, okay? So safety risks in childhood, motor vehicle accidents are the leading cause of death for children in the United States, followed by aspiration of foreign objects, meaning that they swallow something, it gets stuck in their throat, stuck in their lungs, suffocation through plastic over the face, cannot breathe, falls, poisoning, burns, and drowning. These are the biggest safety risks. So certainly we want to make sure that we are teaching the correct anticipatory guidance to avoid these kinds of safety risks from turning into a real accident. For car seat safety, all young children should be in a safety or booster seat until 8 years of age or 80 pounds. So here you can see a booster seat, and we can see this young man here in the back seat, in the booster seat with his seatbelt on. So that's 8 years of age or 80 pounds. And we're going to talk about another topic that is, I would consider to be somewhat of a safety issue, and that is childhood obesity. Childhood obesity is on the rise, along with obesity in general in the adult population in the United States. Here, right now, I think about 35% of all adults across the nation kind of self-report as being obese. That number may reach 50% before too long, maybe within the next 10 years. And so it is an epidemic. It is something that we need to address as nurses in the healthcare setting. And we need to do it through teaching about good nutrition and good exercise. So let's look at a little vignette here, right? We see a young child, clearly overweight, supersizing it at McDonald's. And I'm not trying to give McDonald's a bad rap, but everything in moderation, right? So if we have children become addicted to some of these types of foods as a child, that will carry on into their teenage years. So here we see this individual now moving on to other types of addictive food problems with fried foods and packaged foods and processed foods, contributing to more obesity in the teenage years. By the time this individual is still considered a relatively young adult, maybe not even reached his 40th birthday. We can see that he is walking with a cane, because what will happen is with a lot of that central obesity, that heaviness on the top of the body causes a lot of stress on the knees. I think we learned this when we learned about arthritis. We learned about degenerative joint disease, that arthritis can happen from that upper weight causing too much pressure on the joints, and those bones start grinding against bone against bone, right? We lose that cushion. And so that can result in them needing a single or double knee replacement, which is quite costly as well. But by the time he's 50, he has his first heart attack maybe, and now he's on his way to the hospital. He is now getting open heart surgery. He's in the intensive care unit. So now we've seen how you go from childhood eating habits that grow into adulthood, leading to lots of serious health conditions, okay? So obesity is associated with chronic illness, including type 2 diabetes mellitus, coronary artery disease, arthritis, like I just mentioned, stroke, hypertension, or high blood pressure. Childhood obesity leads to adult obesity and cancer. There is a higher risk of developing cancer in obese individuals. And so as nurses, it's important that we assess our children for obesity and in the clinical setting. When they come in for their well child checks, we check their height, we check their weight, and we calculate their body mass index, or their BMI. And of course, we interview them. So we interview them, we interview their parents. We want to know if they're involved in organized sports. We would like to know what their favorite snacks are. Are they participating in preparing meals in the home? Are they learning about good cooking techniques? All this information needs to be talked about and gathered, and it gives us an opportunity to do teaching if we need to do that. So body mass index is strongly associated with subcutaneous and total body fat, and we calculate BMI based on the individual's height and weight. And so BMI for children is calculated the same way as it is for adults, but then it's compared to typical values for other children of the same age and sex. And so we use the growth charts for that, which you'll get an opportunity to use in lab, practice with in lab. And so the calculation for BMI is their weight in pounds divided by their height in inches times a constant of 703. And then you take that number and you divide it by their height in inches. And the value that you end up with is their BMI. And so here we have an example of a 140-pound child who is 60 inches tall. We multiply that by 703. We get our value. We divide that value by 60 inches, and we come out with a BMI of 27. So, obesity is defined as a BMI that is greater than the 95th percentile. So remember before we looked at the growth charts and we saw these nice little waves on the growth chart, and on the very bottom of the growth chart was the 5th percentile, And on the very top of the wave was the 95th percentile. And what we really want as our children are growing is for them to be plotted somewhere between the 5th and the 95th percentile. So when we are plotting a child's BMI and it gets plotted outside of the 95th percentile or above the 95th percentile, that is when, that is how we officially will use that as a definition for obesity. Now, you got to remember, we also need to look at the child's stature. We need to look at the size of their parents, and we need to consider all that as well, okay? So children with a BMI greater than the 85th percentile is considered overweight. Above the 95th percentile is considered obese. Although we have to do an interview, we have to gather information, we have to look at the child, right? How much fat tissue do they appear to have on their body? Or are they just a very, very big kid that comes from a very, very long line of big people, tall and big, right? Children with a BMI less than the 5th percentile are considered underweight. And so again, if a child falls off the growth chart where they were gaining, weight pretty steadily, and then all of a sudden they're below the 5th percentile, that should be concerning as well. What's going on with their nutrition? Is there possibly a chronic disease that is developing, and that is why the child has lost weight? And so a nurse really needs to investigate when there are changes that take place with a child's growth, rate of growth. Obesity and low metabolism is no longer considered evidence-based. Now, granted, there are certainly families where there's a trait of obesity in the family. We know that this has a lot to do with habits. We do also know that there are genetic components to it, but we don't just sit back anymore and just say, well, the person is overweight because their metabolism is slow, right? This is not just a reasonable explanation. We need to do more testing. We need to find out more about their activity, more about their diet, and we need to get to the bottom of it. Is it emotional eating? And if so, what are we going to do about that, right? Causes of obesity in children obviously are due to excessive caloric intake, not matched with physical activity. Snacking, sometimes it's the parental view of proper nutrition. I mean, some of us have grown up in a home where you had to finish every bit of food that was on your plate, or you were not getting up from the table. And actually, it may not be the healthiest way to teach a child to decide when they're full, okay, that they are done eating, right? And so in another way to look at this might be that, you have to finish your vegetable, or you have to finish half of each of the items on your plate, rather than this idea that you must finish the entire plate of food. Sometimes their little stomachs can't do that. And other things we might say is, if you don't feel hungry, then to finish, your mashed potatoes or your rice or whatever, then certainly you're not going to be hungry for dessert, right? So a lot of times it helps when you say, if you can finish your broccoli, then I know that you'll have room for dessert after that as well. So we want to encourage, praise good behavior, and again, reward it, right, with a fun dessert. And so there are psychological factors, comfort food for kids who are feeling depressed or bored. They're eating out of boredom. and in fact eating while they're sitting in front of the television or the computer or the phone, so snacking while they're doing nothing physical is even a more difficult habit to break, right? And so we kind of don't want to start those habits to begin with. So if the child wants to come home and have a snack after school, it's probably best to do it at the kitchen table and then move on with whatever else is going on for the rest of the afternoon. But the idea of cracking open a bag of potato chips while watching the afternoon TV shows or playing video games, probably not the best habits to get into. So reduced physical activity is another cause, and this is because of the amount of times that kids are spending playing video games, computer time. Somewhat can be contributed to safety of neighborhoods. Kids cannot just go out and play freely the way it seemed like we did when I was a child, because there are a lot of safety considerations in many parts of the country where they cannot just go out and run freely and play. And of course, television, still spend a lot of time watching television, and all these things are contributing to the problem with obesity. This is an older bit of data, but I just still think it's very interesting. So according to the AC Nielsen company, this is the company that kind of tracks our habits for watching television, screen time. They say that the average American watches more than 4 hours of TV each day. That's actually 2 months of nonstop TV watching per year. In a 65-year life, that person will have spent 9 years glued to the television with that 4 hours a day. The number of murders seen on television by the time an average child finishes elementary school is about 8,000. The percentage of Americans who believe TV violence helps precipitate real-life mayhem, it's about 79%. The number of 30-second television commercials seen in a year by an average child is about 20,000. And so we know that the media definitely influences our children. Children under the age of 2 don't learn as well from screens as well as they do from live interactions with real people. Co-viewing media with parents can help protect young kids against many of the downsides of screen time. And so we want to teach parents to peek on in there, see what it is that they're doing online and what they're watching to see if it's safe and appropriate. Television viewing time is correlated with obesity in youth. Meeting sleep, screen time, and physical activity guidelines is associated with the best mental health outcomes in teens, but few adolescents meet all three. And what I mean by this is that really screen time should be limited. What should it be limited to, you ask? Well, the American Academy of Pediatrics says no more than 2 hours per day. And so that's combined. That's iPhone time, television time, computer time, really should not exceed 2 hours per day. We all know that we should be getting about 30 minutes of moderate exercise, at least 3 to 4 times per week, and sleep. They should be going to bed at a reasonable hour and getting a good night's sleep, 8 to 9 hours at least. And that's really in an adult. Kids, especially young children, 12 hours of sleep at night. So, anticipatory guidance counseling, turn off the TV go outside and play as long as it's safe in your neighborhood to do so. And if not, let's get more families out together at the park, doing things together, being active, and expending energy. So behavior modification, getting kids to participate in an exercise program, getting them to participate in organized sports, you know, and sometimes it takes a few tries of a sport before they find something that they like. Avoid snacking while watching television, for sure. We want to work on quantity reduction, so smaller portions of food, and the quality of the food consumed. So we want to teach even kids, right? Lower fat foods rather than the high calorie packaged and processed foods. And so this is what the new pyramid looks like. This is the mypyramid.gov, where we no longer just have the grains, the vegetables, the fruits, the milk, the meats, and the breads, right? The food groups listed, and the amount of servings that they should be having per day. We can also see that now they're encouraging to balance out the food intake with exercise. We can see the kids out walking the dog, playing soccer, out picnicking in the park, riding a skateboard, and so on and so forth. So this is what the recommendation is for what a plate should look like, okay? So we can see here that the plate mostly has a larger portion of vegetables and fruits, and then grains and proteins. Lean proteins is what we want to encourage. And then we can see a good source of dairy or calcium is also important as well. I think it's easier for us to just look at a plate like this and say, all right, well, this is kind of what, you know, our plate should kind of look like, instead of, you know, a heaping mound of spaghetti or rice or bread, and a little bit of vegetables and maybe no fruit at all, or, you know, a large piece of fried chicken and a large big lump of mashed potatoes, or rice, of course, more popular in Hawaiian culture. So for anticipatory guidance for children around the age of 10 years old, it's kind of time to start to begin discussions in preparation for upcoming puberty. And we might look at our 10-year-olds and think, gosh, you know, they just are little kids still. They look like little kids and they are little kids, but children do begin changing, their bodies begin changing around the age of 10. And so we need to start having conversations in girls about menstruation, starting their period, sexual intercourse, reproduction, and sexually transmitted diseases. And I know it sounds alarming to think that, you know, we would be having these talks with children this young. However, being educated is really shown to protect children, to protect them against these things that are out there. And so having these conversations or signing the form where they're allowed to have these conversations at school. Nowadays, they'll send a permission slip home for mom and dad to sign so that they can learn about some of these things in school. I think it's better to have open conversations at home with mom and or dad. I think having children comfortable talking about these things is really the safest way for them to get through this developmental stage. And so Tanner stages are a scale of physical development in children, adolescents, and adults. And you can see here in the picture, there are different stages, starting with stage 1, We can see that it's defining physical measurement of development of the external primary and secondary sex characteristics. So we can see starting at stage 1 with small breast buds through full development with all the other primary and secondary sex characteristics. And what do I mean by that? So what does that mean? So primary sex characteristics are external and internal organs that are necessary for reproduction. So we're talking about primary sex characteristics. We're talking about the penis, vagina, the ovaries, and the testes. These are all the organs necessary for reproduction. These are primary sexual characteristics. Secondary sexual characteristics are things like voice change, hair growth, axillary hair growth, breast enlargement, fat deposits that start through puberty. These play no direct role in reproduction, and they are considered secondary sex characteristics. So, we have come to the end of our presentation today. I hope that you have learned something new about children and development, and that you can take this information with you into the clinical settings if you're working with children and their parents to help them live happier and safer lives. Until we meet again, aloha.